All right, welcome everybody for Grand Rounds at the Institute for Health Policy Studies. My name is Dean Schillinger. I'm a professor of medicine at UCSF and a primary care physician at San Francisco General Hospital, where I direct the UCSF Health Communications Research Program, and which is why I'm particularly pleased to be able to introduce today's speaker. Dr. Sarah Gollust is a professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health. She is a founding member of the Collaborative on Media and Messaging for Health and Social Policy, an interdisciplinary group of researchers who study how media and messaging shape public opinions, attitudes, and behavior. Dr. Gollust is a social scientist studying the intersections of communication, politics, and health policy. I don't know why that would be of interest to any of us these days. In her past research, she has examined media influences and public opinion around significant health policy issues, including obesity, health disparities in the Affordable Care Act, and cancer screening. She also has examined how research is translated into health policy making. From 2016 to 2022, Dr. Gollust was an associate director and then senior advisor of the Robert Wood Johnson Foundation Interdisciplinary Research Leaders, a national health equity research and leadership program. Dr. Gollust completed a postdoctoral fellowship in population health science at the University of Pennsylvania and received her PhD in Health Services Organization and Policy from the University of Michigan. And I learned last night that both of her parents were journalists, so that in part explains her interest in the media, communication, and policy. So Sarah, let me hand it off to you. The title of Sarah's talk is Communication about COVID-19 Health Inequities, Implications for Journalism, Policy, and the Public.
Thank you so much, Dean. When people ask me why I'm interested in this work, sometimes I say it's genetic. So that's a genetic explanation for why I study the media, or maybe it's environment, right? We can't pull those apart. So thank you so much for inviting me here to present on my work. I'm really delighted to get a chance to meet many of you in person and talk to others virtually. I do think I'm happy to answer any kind of burning, clarifying question if anything comes up during, but otherwise, the way I've timed it, hopefully, there'll be plenty of opportunity for discussion toward the end. And with that, I'm going to set my timer so I can hold us to that. All right. So the plan for today is I'm going to start by introducing kind of my overall research approach, kind of how I see my work within the broader context of health communication, and introduce my team and the work that we do in the Collaborative for Media Messaging for Health and Social Policy. And then I'm doing just kind of a spotlight into two empirical studies to share with you today. One is on public opinion research that we've done over the last 3 years, but focusing on some data collection from the spring of 2023 on public awareness and perceptions of COVID-19 health inequalities. And then I'll talk about a qualitative project in which we've been working to identify the sort of needs and challenges of communicators in practice surrounding issues of health equity. So there are sort of many different pathways or mechanisms through which different forms of communication can have an impact on health equity. And we can think about this impact as being sort of positive, right? Enhancing health equity, advancing health equity, or reducing health disparities. But it could also be negative. Communication can also have a contribution in expanding health inequities that already exist. And so I think about sort of the broader landscape of health communication as encompassing these kind of three buckets we see. So on the top arrow, we have our traditional strategic communication or campaign. So something like a public service announcement to get a vaccine. Guideline dissemination, another sort of mechanism through which information is disseminated into the universe in the hopes that there's practice changes, policy changes, or individual patient behavioral changes. And advertising and marketing is sort of another bucket. Strategic, designed to get you to do a behavior, to buy a product, to get a vaccine, to engage in some individual behavioral choice or product. Then in the middle, we have media about health and healthcare, which is rarely strategic or purposeful in the same way as a PSA. This might be information in a news article that has incidental, that members of the public or patients are exposed to incidentally while they're, attempting to read the latest Taylor Swift news. They happen to see an article in the paper or on TV or in their social media feed about melanoma. So that has implications for then how they think about the issue. And then last, there's a bucket of interpersonal or interactive communication. So doctor-patient communication, caregiver communication, or zooming out a bit to the broader social and political and social determinants of health landscape, that might also include people's interactions with social service providers or with policy environment, with their with Medicaid enrollments or the communication that's required to access services or access policy. Um, and as I mentioned before, each of these types of communication has the potential or promise to reduce health inequalities, but also has the potential or threat of increasing health inequalities because we know from research from Vish Swithnath and many other people that there's also this sort of the foundation for inequality is also baked into how people engage with, respond to, or act on health information. So if people don't engage with it, or if members of target communities don't have the environments or resources to take advantage of messages in the communication environment, that can contribute to more resourced populations being able to take advantage of health information and less resourced populations being less so. And thus you could see inequalities widen as a result of a communication intervention of some kind. So layering on all of this is, although I've dabbled with each of those buckets, the focus of my work around communication is a little bit different. So I'm interested in not communication for the outcome of health inequity or looking at health disparities, but actually communication about health equity. So I've been interested for a long time in thinking about the volume of attention, kind of how often the news media even engages with issues of social determinants of health or health equity or health disparities, to get a sense of how salient that information is among journalists, among media producers, and then also the content of that coverage. So what is the quality of that coverage? And so a lot of my work around news media looks at, does content analysis to understand the messages about health equity in the media. And just like I described with there being sort of maybe more positive, normatively good outcomes, there can also be sort of less good outcomes as a result of this communication. And so I think about the sort of potential outcomes of this type of communication in 5 different buckets. So there could be increased awareness. So more attention to health inequities in the media could lead to readers and audiences coming away with more understanding, more awareness that those issues exist. That itself could contribute to agenda setting, to people, policymakers, members of the public thinking those issues are more important. So not just that they're aware of them, but that they're important, that they're something that ought to be addressed in society or by governments or by local community organizations. I'm also really interested in causal attributions. How do people make sense of these issues? Do they think about issues of health inequity as related to the individual, as internally oriented, or are people engaging with media understanding these issues in a systemic or structural way? Those causal attributions, psychology research, social psychology research tells us, are directly related to people's understanding of policy. So when an issue feels very much like it's an individual's to deal with, an individual's fault, they're less likely to think that there's a role for policy in shaping that, and more likely to think that this should be an issue that families or individuals themselves deal with. And then last, I'm really interested in understanding the implications of communication for people's policy engagement, how they're engaged in the policy process, whether and how they're mobilized, whether they participate politically. So I've studied things like voting behavior as an outcome of interest to better understand that sort of big picture connection between the information environment and the policymaking process. So I came to be interested in this area of communicating about health equity a while ago, and my co-authors and I in 2013 published a paper, Communication About Health Disparities in the Mass Media, distinguishing this relationship between communication with outcome of health equity and communication about health equity. And we identified this framework, and we're particularly concerned about these potential kind of unintended consequences of communication about health equity. People resisting or reacting to this information. The information might further polarize an already polarized populace, or that information about health equity could activate stereotypes about people, about groups. And as sometimes happens in my work, I look back at papers I wrote a long time ago and think, wow, that made a lot of sense. Because we are in a moment where I think the reactance, the polarization, and the stereotype activation feel very raw and very threatening. And we'll talk about that further. But we wrote it down in, whenever we submitted the paper, probably 2010 for a 2013 publication. So the communication context now. On the one hand, there is a lot of information in the broader information environment making the connection between systemic factors and health. So for instance, on the left, you can see these are documented jurisdictions at the state, federal, county, or city level declaring racism a public health crisis. Surely that happened here in San Francisco. It happened in Minneapolis as a direct result of George Floyd's murder in Minneapolis. And this just shows the sort of exponential increase in public health authorities making a declaration that racism is a public health crisis. And you can see on the right, this was just my little screen grab of PubMed back in October of articles of research literature in medical and health journals with the keyword structural racism in health. So you can see that on the sort of policy and public health practice side, as well as in the research community, there is just a lot more attention to issues of structural racism and the relationship between structural racism and other systemic factors and health outcomes. And so there's more potential for this information to be available for policymakers and the public to grapple with. But at the same time, there's also a heightened context of political polarization right now and competitive messaging surrounding these issues. So our research team has been trying to examine attention to racism and health inequity in the media, and also attention to issues like critical race theory in the media. And we're documenting how a rise in attention to racism, we've seen that as preceding a rise in attention to essentially attacks on systemic racism as a racial equity and racial justice issue. But we have relatively limited research on communication about equity in these conditions. Two-sided messaging or competitive messaging is no surprise in public health, right? There's always been an industry side. So think about sugar-sweetened beverage messages, tax messaging. There's the public health folks and advocacy organizations trying to communicate about, whether the health or social consequences of sugary drink intake, and then you have the Beverage Association on the other side. And so this kind of two-sided messaging environment is also really, really salient around health equity messaging in particular. But there's also limited and fragmented support for communicators communicating about health equity in this context. And so these issues were the justification for our proposal to the Robert Wood Johnson Foundation to create this mouthful of an acronym. We call it COMM because collaborative on media and messaging spells calm. Cute, right? But the full name is the Collaborative on Media and Messaging for Health and Social Policy. And we are aiming to fill this gap for sort of more rapidly responsive, engaged communication research that's centered around health and racial equity. So that's kind of our team's charge, our value, our orientation. And we do this research using kind of three modes. And so our colleagues at Wesleyan are working on doing real-time media monitoring. So using computational methods as well as human regular old content analysis methods to understand the media landscape surrounding in both political messaging and television messaging around some of these issues related to health and social policy. Our colleagues at Cornell University, across the communication department and public policy and political science, are developing research to say, okay, we see this message emerging in political discourse, media discourse, let's test that message. So doing more rapid experimental work to understand the implications and potential effects of different messaging strategies. And then I lead up our team at the University of Minnesota, who's interested in how do we get this research, how do we identify partnerships and work more closely with communicators and practice communities. So our team is wonderful. Just a quick shout out because they're involved in everything I'll be talking about today. A team of interdisciplinary researchers spanning political science, communications, psychology, policy, and public health. I've listed the names of the faculty members, but even more important certainly are the postdocs, research assistants, and research coordinators that we've been able to fund and support through the Robert Johnson Foundation at each of our 3 institutions. So what do? We have various different projects that are sort of aiming at those three ideas on that previous slide: the media monitoring, the media effects, and the engagement. So one project I'm really excited about and happy to talk about separately in one-on-ones or Q&A is a CBPR project with a power building organization in Colorado who's working to build narrative change strategies that are accompanying their campaigns and the movements that they and their leader and grassroots organizers are working on. And so communication strategy is a really important part of their work, and we're working with them on helping to test and evaluate their messaging. As I mentioned before, the Wesleyan team and the Wesleyan Media Project does monitoring of the media landscape and television campaign messaging environment. Published a paper recently on references to race and racism in political communication. Talk about a hard RA ship. It's watching hundreds and hundreds and hundreds of political ads from the midterms, and those RAs are gearing up to do it again in 2024. Right. And I mentioned our work on TV coverage of racism and CRT. And then just example experiments from the Cornell team working on understanding how different ways of framing the child tax credit, a policy that has very strong evidence for equity enhancing effects, reducing poverty, reducing racial inequality and income, and looking at how people respond to different ways of framing that, as well as other work on trying to message and frame structural inequity in different ways. But I'm not talking about any of those. So as I move into the meat of what I'll be talking about today, it's really on understanding this context, the context among the public and the context for communicators in 2023, now obviously 2024. So I'll be sharing snapshots from 2 studies, one on public opinion about disparities, and one of this qualitative study on communicators' perspectives. All right. So our research team had the opportunity to go into the field in April of 2020 to try to assess public understanding of the already apparent disparities in COVID-19. So we rapidly got ourselves together, drafted some survey questions, and developed a relationship with the NORC AmeriSpeak group. So NORC AmeriSpeak is a nationally representative panel of research participants. They have a bi-monthly data collection of about 1,000 people each month, and researchers and others are allowed to put shared questions on this survey. It's a relatively low-cost way to get rapid, nationally representative public opinion data. And so our team developed our questions, and we fielded those questions in April 2020 on the Omnibus, which is the shared platform, in April 2021 and April 2023. Researchers can also work directly, not on a shared platform, but use NORC AmeriSpeak as any other kind of survey platform for recruitment. And we had the opportunity to do that in August 2023 and add these questions to it. So we ended up with 4 time points where we used the same questions for cross sections. So they're not the same participants, but 4 discrete cross sections to get a sense of public perceptions of health inequalities in COVID-19 over those 4 time points. Jumping straight to the punchline. So we asked about 4 different types of mortality disparity. And so what we asked, we said, how much do you agree, from a rate from strongly disagree to strongly agree, that there are disparities in mortality from COVID-19 based on, this is hard to see probably, chronic illness, so you'll see it again in different ways. So people with pre-existing conditions and those without, or age, people who are older compared to younger. And we found broad and widespread recognition of these disparities. So even in April 2020, you can see the length of the blue bar. So the blue bars represent strongly agree with the sentiment. And then the bars are ordered by time point. So April 2020, August 2020, April 2021, and April 2023, you can see broad and widespread understanding or recognition that there are mortality disparities by chronic illness and by age. Very few people disagreeing with this, and a relatively small number saying they, I don't know, neither agree nor disagree. But we see it declining over the time series. So by the fourth wave, people were less likely to acknowledge that these disparities exist, likely a result of mortality from COVID being less resonant by April 2023 after vaccines have been introduced and so on. But punchline, we see far less recognition of mortality disparities by race and income. I know there's a lot to absorb, but just squint and you can see that the size of the blue bar is much lower, more along the lines of 50%. So only about half of the public in April 2020 recognized that there were mortality disparities by race and by income. And sure, this was still very early on in the pandemic. The public health community was certainly activated to issues of inequity, but it wasn't necessarily a major story in the news, right? It wasn't necessarily the case that many people would know that there were evidence of racial disparities or socioeconomic disparities in mortality. But we thought for sure by August 2020, after the racial reckoning and after many of the public health organizations I showed on the previous slide were documenting racism as a public health crisis, we thought we might expect to see increased awareness of racial disparities in particular. We didn't see that. You can see the bar here for racial inequalities in August 2020. If anything, got a little bit shorter, right? So less public awareness of racial disparities and then continued to decline over time. So that story here, the headline, the public was much less likely and is continuing much less likely to recognize that there are mortality disparities by race and income relative to by age, that older people and people with chronic conditions were more likely to die. So in April of 2023, in addition, yeah, please.
Did you happen to ask a parallel question about, I don't know, diabetes or cancer? Like how much is this a COVID phenomenon versus a generic?
It's
You
a,
don't believe in
it's,
race disparities.
so I think it's that. So I don't have that data in this talk, but I have looked at survey data on public recognition of disparities. There have been studies by RAND, KFF, the Harvard, Bob Blendon's polling group at Harvard. There have been studies across over years, over time, and they cap at about half the public. So I have looked, and on all sorts of different contexts. So I've seen public opinion data on people's understanding of infant mortality disparities, life expectancy disparities, particular chronic diseases, and it's not well understood, yeah, by the general public. So I think that's a really good question. So yes, it's a COVID thing, and I think it's a understanding of health inequity question. Yeah. Yeah, please. Just wait. I sure do. Yeah, that's like 2 slides from now. All right, so um, we had the opportunity, so we'd only asked because we went out in the field in April 2020. We wanted to ask 4 questions. We asked those 4 questions consistently, but in April, when we went back into the field, we asked about other sources of disparity or other inequalities in mortality. So the gray bars are the levels of recognition in 2023 of the 4 original set: chronic illness, age, low income compared to high income, Black compared to white. And then we asked how much do you agree that people who are unvaccinated are more likely to die of COVID-19? And we can see only about 45% of this 1,000-person sample agreed with that, and even lower salience to the mortality experienced by American Indian populations and Hispanic populations. So low overall levels of understanding of these inequities that in the sort of public health and medical community um, we see as just part of an incredibly important part of the pandemic experience. So red and blue bars for you. Um, so breaking this down by partisanship, yes. So as we think about sort of what might be the limit on public understanding of disparities, partisanship plays a role. So interestingly, there are no significant difference between people who identify as Democrats and people who identify as Republicans in their recognition of disparities by illness status or age. But for all the other types of disparities we asked about, we see this persistent pattern of a partisan gap in recognition that these disparities exist. So the fact that it doesn't show up for these types of disparities tells me it's not an issue of disparities generally, but of the type of disparity, the social and racial disparity that activates a partisan heuristic in engaging with this survey question. Right. So we also have to recognize this is people answering a survey question. It's not a dialogue with them. It's not engaging with people to understand, to try to get a sense of their beliefs in any kind of qualitative way. But in answering a survey question, we see this partisan patterning of responses, which suggests a heuristic processing, or in psychology or political science, it's called bias processing or motivated reasoning that contributes to what we see to be a partisan way of engaging with this information around vaccination, low income status, race and ethnicity that doesn't show up in thinking through chronic illness or age-related disparities. And this pattern persisted across all 4 time waves. So again, never see a significant difference between Democrats' responses and Republicans' responses to these questions, and this persistent and even widening gap in how people identifying as Republican or Democrats are engaging with these survey questions in their survey response. So there's lots of reasons that the research literature in political science, political psychology, and health communication has to explain some of these phenomena. So one is that it reflects different levels of awareness based on different exposure to either interpersonally the mortality itself, right, or the mediated depictions through media sources. Or it could be a resistance, as I think Dean was sort of getting at, a resistance to acknowledging the inequalities that exist. And we can't distinguish those pathways in this data. So we also asked about perceived causes for these disparities. So these data are from only a smaller subset of our survey respondents. So only among the about 300 people who said that racial disparities exist. And then that's broken off even further by, we asked them, okay, you told us that there are racial disparities in COVID-19, and then there was skip logic. What do you think the causes of those disparities are? You can pick up to 3. We modeled this after another nationally representative survey that RAND had done through funding from RWJF as well. And so people could select which of these causal attributions they believed explained the disparities that they acknowledged exist. And you can see that access to healthcare was the sort of dominant causal attribution that people identified. Next common was economic resources, a sort of socioeconomic, social determinants explanation, and living or working conditions. So these were common. Only access to healthcare was identified then more than half, but all 3 of these we can think of as sort of systemic explanations for inequality, which is great, right? It means that these ideas that systems matter, that people's resources matter, and the environments in which they live matter for health are kind of sinking in. Racism specifically only about 1 in 5 identified. But also genetics. So 1 in 5 people identified genetics as a causal attribution for racial disparities, which is incorrect. Um, Personal choices and behavior identified by about 20%. Beliefs about health, access to education, sort of very low salience that education has an impact on disparities, and luck uh, was identified by a handful of people. The samples were small, so I'm not breaking out by partisanship, but I'll just say the asterisks indicate there were only differences by partisanship for these three, with independents more likely to identify luck as a causal attribution, and then Democrats more likely to identify access to healthcare and economic resources. Yes, please. They picked up to three. So we said many of these mortality disparities could be caused by many things. Which of this list do you think you may select up to three? Yeah. Yeah. Mm. Yeah. 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 So we did. We asked other. I didn't put that on this, but we did ask. We gave them an other option, and I would say that probably only 19 people wrote in an other. Right? They're taking a survey. They don't want to spend the time, but of those, it was a lot of that. Obesity obesity was mentioned probably most. Yeah. Okay. So we also wanted to dig into systemic racism generally as a cause of health disparities, and so we adapted a question from RAND's RWJF survey initiative, which they started with an explanation for what systemic racism is. I'll read it aloud. Systemic racism refers to policies and systems that reinforce racial discrimination and unfair treatment of some groups, such as where people get to live or who gets bank loans. This type of racism can be so embedded in the institutions and practices of society that it still exists even if individuals don't want to discriminate. Then, for the following question, please indicate how much you agree with this statement. And this was broader than COVID. It said one of the main reasons that people of color, e.g. African Americans, Latinos, have poorer health outcomes, e.g. higher rates of diabetes, more deaths from coronavirus than white people, is systemic racism. And again, we see this political patterning of responses where overall about 30% of people said they agreed with this statement, more among Democrats, far fewer among independents and Republicans. And it was lower still than when RAND fielded the survey item in the fall of 2021. So they found about 40% of the total population agreed with the systemic definition, as a systemic relationship between racism and health outcomes, and we found lower levels. So closing this section, we were also really interested in this idea that's been emerging in some of the social science literature on the potential for backlash to causal explanations of health disparities that identify racism specifically, or simply identifying that there are racial disparities. So a study came out by Skinner Dorkanu and colleagues in May 2022, which raised a lot of alarm among the public health community, at least in sort of the circles that I operate in, because they found using an experiment, so they experimentally assigned white survey respondents to see messages about health disparities in COVID-19 based on race, and others not to. So they had a control group. And they found that the people that were exposed to messaging about disparities had lower levels of empathy and lower levels of support for mitigation practices like mask wearing and crowd restrictions than did people who didn't see these explanations. So this raised this concern that there's backlash to messaging about health disparities. This study followed another study also published in Social Science and Medicine the previous year, which showed a very similar finding, how information about race-based health disparities affects policy preferences. And there's been a third study published in the political science literature in the American Political Science Review that found a similar reactance to information about racial disparities, focusing on a white-only survey, a respondent survey. So we were interested in these findings and wanted to know how perceptions of disparities might relate to future sort of forward-looking policy related to pandemic mitigation or infectious disease control. So we asked the question, overall, how much do you support or oppose the authority of state health departments to implement policies to reduce the spread of an infectious disease? And found this is when you get to decide if you're an optimist or a pessimist. So we found overall about 53% of the public in this survey in April 23 said they support the authority of health departments. I see mainly pessimists based on your eyes. That only 53% of the public were supportive of the idea of state policies state health departments passing policies to reduce the spread of an infectious disease. And again, the same sort of as now expected polarization based on partisan identification. But we were looking at, based on this experimental evidence, these 3 studies were showing that when you assign people to read messaging about health disparities, they are less supportive of policy. So we did a simple regression analysis to see whether that would be true in the observational setting, where we're not exposing people to information about racial disparities, just asking them if they recognize that there are racial disparities. And we found that the only things that mattered for people's support for state authority for public health departments was partisanship and perceptions of racial disparities. So controlling for all of these things, so all these demographic factors made no difference. They were not related to people's support for public health authority, except for partisanship, with Republicans and independents much less likely. But even controlling for that, we see people that recognized, that were aware that there were racial disparities in COVID-19, they were more likely to support the public health's ongoing authority to implement policies. And that, we presume, is because that recognizing that there are these disparities also may relate to people's attitude about the importance of protecting a community, or it may be some unmeasured factor that relates to people's belief or value as it relates to community health, to equity more broadly. And we didn't have other data sources to really try to isolate this. Okay, Act 1. Act 1 of my talk is over. Actually, Act 2. And so we'll conclude with talking about some of the qualitative work we've done to understand communicators' perspectives of their needs in this environment. Okay, so we wanted to ground our research agenda with the perspectives of communicators. So recognizing that in order for communication research to have an impact on communicators, we need to know, what are the challenges communicators face? What are their research questions, and how would they want to receive research? The audiences that we were excited about, including in this study, included public health practitioners, thought leaders, people who are engaging with media, or our thought leader category also included some former media people who were thinking more at the sort of meta perspective on communication. Organizers, so people working in either advocacy organizations or power building organizations, where their role is really thinking about mobilization toward equity. And then journalists, and these are importantly all journalists who had some kind of beat or evidence that they were covering health disparities. So we're not trying to generalize in any way in any of these groups, but particularly I want to point out that these are journalists who are writing about health disparities and who we identified for their writing. We started recruiting for interviews in November of 2022 using a kind of snowball sampling approach. They were conducted over Zoom from 30 minutes to an hour. The interview guide consisted of 5 different domains. I'm only going to talk today about the barriers communicators face, the resources that they relied on. So we asked, when you communicate about health equity, what strategies do you use? What barriers do you face? What resources, if any, do you draw upon? And what research questions do you have about this intersection between communication and health equity? If anyone's interested, we used Otter AI to transcribe. So we used artificial intelligence to do our real rapid time transcription, so that as soon as the interview was over, we could review and write field notes on it. We developed our code book based on these field notes. Then we went back and coded the full transcripts after that. And we met last week, just in time, as a team to really dig into our key findings. So we ended up with a final sample of 36 people. more than half identified as people of color, more than half identified as women. And you can see we had 13 people who were in the sort of public health, either government space, nonprofit, or philanthropy, 8 journalists, 7 thought leaders, and 8 advocates. This is my transition slide that shows our code book. It also identifies kind of where the most of the conversation was around. So really the key challenges node was where we got most of that's where most of the interviews and most of the excerpts were coded. Okay, so what did we hear? We heard a lot, a lot of tensions that kind of have already, that were sort of hinted at through some of the public opinion data. So we heard tensions. This is particularly true of our 13 public health people we spoke with, feeling tensions around concerns about alienating audiences when they talk about health equity. And that meant a few things. One was this partisan concerns, which were certainly on the minds of many of our public health communicators we talked to, but also geographic. So really thinking about um, for instance, someone working in a local health department or someone supporting a local health department saying, I don't know if these explanations of structural racism are going to resonate in this rural health department or in this more homogenous white county. But we also heard alienation about whether to use and when to use more explicit language naming structural racism and when to not, and how to center racial inequity, how and whether to center racial inequity in communication about these issues relative to other identity dimensions, particularly hearing reactions often when they were sort of really race-centered in their communication, hearing people saying, well, what about class? Or what about these other issues? We actually had 3 people who talked about those studies. So 3 individuals, only 3, but 3 said, I read the study in social science and medicine. So they had been aware of this study that had suggested there could be disparity or could be backlash in response to messaging, and we're actually taking that to heart and actually very concerned about too much messaging about disparity leading to people, leading to white audiences withdrawing or not supporting policies. And then lots of different sources of resistance. They talked about confusion about key terms, mistrust, which was both sort of justified mistrust in systems and also mistrust in systems that have been oppressive and marginalized folks, but also this other type of mistrust around science and media institutions. And so mistrust was one of those themes that was shared across all 4 groups, concern around the mistrust of audiences. Some concerns around minimization of health equity as important or outright denial of racism. A really important theme was that audiences are cynical, that there's nothing can be done. And so hearing cynicism and fatalism as a challenge that communicators are trying to overcome. The sort of allure of individualism as a causal explanation for systemic factors was also raised. And then several people talked about the moment in time, the politically motivated movement, making conversations about health equity or silencing conversations about health equity. And they called this the CRT, the anti-CRT movement, the anti-woke movement. So just a few quick examples. So with regard to that challenge about how forcefully to center race in communication by a public health department about health inequity versus other identities, someone working for a state health department said, sometimes I think there's a tension around a focus on elevating health for people of color and American Indians, but I'm always a little worried about, if you're a poor white person who's like, what about me? Why don't you care about me? The counter to that, and the other quote, number 33 from Public Health, who was saying, we have to name structural racism. She says, how can you have a discussion like this without calling a thing a thing? So using more neutral language also has alienation potential. One thought leader speaking to the backlash that she faced in communication said, I found that it's becoming easier to be quiet and to not engage or to not speak up. I think it's because of the intensity of the backlash. And an advocate also speaking to this environment of questioning structural racism, she says, my entire life I felt that this is a sociological fact. You're denying evolution and gravity when you're denying structural racism, right? And then another set of challenges that communicators shared with us were institutional in nature. So those were more audience in nature, and then their institutions came up as another theme of challenge. So gatekeeping by reporters or editors. Again, we only talked to 8 reporters, but many of them were reporters of color writing about health equity issues over the course of the pandemic, and they identified real gatekeeping where they would want to write a story one way and their editor would push back and change it. One went so far as to really call out the racism in the structure of the media institution in which she worked. But there were other sort of, less explicit resource limitations that related to the news production process for the journalists. And this was an issue that came up mostly among journalists, although resources for communication generally was an issue among public health communicators and advocates as well. But having access to diverse sources and messages to be able to tell a different type of story is something that the journalists talked to us about. And then a sort of broader theme around just a fragmentation, both among the media communicators, the fragmented media landscape, but also the fragmented landscape within public health communication as well. So a few examples of those with regard to the sourcing issues. A journalist told us when you only have 5 hours, so 5 hours to file the story, the only person you're probably going to talk to is a public information officer and a doctor. They're the ones who are available. But when you create the community story, you have to work on your own time. You have to get those sources a week or 2 weeks in advance. So they're just not available on the same time frame that the sort of more traditional sourcing often is. A journalist who was talking about racism in their media institution said the editor is always coming back to her and saying, can we really say it was racism? You know, you're having to explain over and over again, like how racism works in healthcare. So that's how systemic racism thrives, not only within what gets covered, but also in terms of how things are covered. And then the communicator commenting on the fragmentation, that public health communication happens in 3,000 health departments instead of one field. So I want to make sure we have time for comments, so I will be fairly brief on the resources and needs. So generally, we find that communicators are doing this work without a lot of support, without a lot of shared resources, messaging, or otherwise, or trainings. They want more of that. They know some of it exists, but it's all relational. It's sort of who you know. So when we asked about, do you ever think about drawing from research in supporting your communication? It was, sure, I know this one person at this school of public health or something, but not, or I get the table of contents from this particular journal, so that's how they're aware of research evidence, but not a sort of systemic way of accessing research. And we heard over and over again about the need to build communication infrastructure surrounding health equity specifically. They identified lots of really kind of robust research agenda around questions that interested them as communicators. Lots of attention that the journalists really wanted to know, does their work to identify diverse sourcing, does it make a difference? To what extent does it matter who gets sourced in a whether it's a TV news spot or print news? This anxiety about disparity messaging came through, asking for really wanting to know more research on that. And lots of work on these sort of top 2 buckets, lots of questions about what does it take to depolarize or depoliticize the climate, and how do we increase trust, not only within public health, but also in science in general and media. And then on the sort of bottom 2 research question buckets, there was a lot of interest in changing the dialogue around disparity from deficit framing to asset-based framing. How do you talk about strengths in community rather than deficits? But real questions about how that happens and how that gets implemented into media and into other forms of communication. And then a whole set of questions around thinking about community-centered narratives, or Black-centered in particular narratives around questions of equity, rather than framing issues from always a relative Black-white context, was a real need among that we heard among the communicators we talked to. So a few concluding points. So clear from the public opinion work that this kind of heuristic processing, using partisan identity to interpret questions of inequity, is persistent. That structural stories and systemic racism are hard to tell and hard to, I guess, have traction among the public, right? We're seeing this sort of like relatively low level of awareness among the public about these issues. I think research can help identify ways to tell structural stories better in a way that might have greater understanding and less resistance. And also really work is needed to understand different variation in how people respond. So not just looking at partisanship, but looking at more other types of intersections across the public, such as in age. We heard also from our interviews that people said you really need to better understand young people and how they're responding. Um, and last, I want to shout out to Dean's work. His back is turned, but really applaud his opinion piece, commentary, and JAMA from last fall, identifying the need for more health communication resources. So both the interviews that we did and the public opinion monitoring that we do confirm this really important need for more investment in these questions around politicization and misinformation, and also thinking about health equity specifically and the specific challenges of communicating about health equity within this particular political climate. And so just pulling out a quote from his piece, this has happened at a time when the communication ecosystem for science and health information, sorry, this being the pause in funding, pause in robust federal funding for health communication, has happened at a time when science and health information has become increasingly contaminated, noxious, and politicized, a development that has significantly undermined public health and caused harm to millions. So thank you for writing that piece. Really echoed the voices of a lot of colleagues and peers who I work with. And so I think that also the interviews that we've done have really pointed out the importance of having stronger relationship across all these sectors, from research into practice into organizing, because people are facing similar threats and are not necessarily have the infrastructure or ways to work together in response to those threats. So thank you.
So I'm going to take the executive privilege and ask the first kind of meta question, then we'll pass it to the Zoom and then back and forth. What can you tell us from the political science literature about the ways in which media does or does not affect policy making, insofar as, you know, the disparities that we observe are primarily driven by large policies that affect structures of our society? What's the R squared? I mean, how important is this to changing political discourse and policy making? Is it a very small drop in the bucket? Is it a significant drop? Can you give your thoughts on that?
That's a great question, and I can't answer with any precision. So yes, there has been work in political science trying to understand the relationship between media, public opinion, and politics for decades. We know there's a correspondence, right? So across many, many studies, we see a correlation coefficient that sort of public sentiment in aggregate matters, and we see a responsiveness in what happens in policy. It's often thermostatic is how they define it in political science, which means kind of the temperature of the public goes up, policymakers might react in accordance with what the public appears to want, and then the public cools and policymakers stop paying attention. And we could see this like with the Affordable Care Act. There was sort of an increase. We see policy action finally to reduce some of the gaps in health insurance status. The public mattered in that case. There was a lot of, looking at polling data from 2009, 2008, in advance of President Obama making that a priority. We saw evidence that the public was anxious and ready. And then we see the public saying, whoa, 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 you went a little too far, and there's less. Well, that's a whole other story. But
is the media the driver of that public sentiment?
So when you ask the public where they're getting their information about healthcare policy, the media is the top thing they see. So you have to draw the dotted lines a little bit, right? Because people's experiences with policy environments are most often mediated, right? People aren't directly necessary. People are engaging in some ways with certain policies if they directly, use SNAP, for instance, or they use Medicaid, or they have family members who do. So those experiences matter. But media tends to be sort of the second biggest source of information people have about policies, about their advantages, about their limitations. Often the media depiction of these issues is sort of not helpful, though, because media depictions of policies can be really polarized and really contribute to the partisan understanding of issues. But that is where people get their information, particularly about health and social policy. So there's also the case that this is a sort of policymakers are people too, right? And policymakers also are, there's evidence that they're absorbing issues of like what are the agendas to work on based on what they see in the media agenda and vice versa. Um, so, okay.
All right.
Hi, I'm Laura Schmidt. Um, I'm a sociologist, so disclaimer. Uh, um,
Welcome.
yeah, um, I look at the period we're in right now and, rising nativism and declining trust in institutions. And I think about the way this whole discourse has just become really polarizing. And so you can't bring up race without polarizing. It's just too charged in this. And if anything, things are moving more towards it reminds me a lot. Early in my career, I studied the American temperance movement, and it reminds me of the late 19th century part of the temperance movement, which got really aggressive with the Anti-Saloon League and and it was a right-wing social movement that led to a constitutional amendment that lived for, you know, 20 years, prohibition on alcohol. And so that's where I think things are headed. And so is anyone in this conversation thinking about reframing race or thinking about ways to distract to reframe policies that are aimed at remedying deep structural inequities, but in a way that doesn't really talk about race? Because, and I'm thinking about the woman who wrote the book on the swimming pools in the South and
Yeah.
how, and I think about the Affordable Care Act and all the people who died in the hospital from a refusal to, participate in vaccination programs. And and I think one of the problems that we have is we don't take ideas seriously enough, and we don't really understand that people don't necessarily politically follow their personal material interests. People vote in ideas really, really matter. And when an idea has become almost toxic in terms of having a national conversation about fixing a problem, I wonder what are the scripts and what are the available ways to address structural racism in a way that isn't provocative? Because and I'm not saying that because I support what's happening here.
Yeah.
I'm just saying that the political divisions are so extreme, and we know where it goes, and there's enough polarization and enough people in this nativist movement that we should be taking it much more seriously in terms of protecting health
Yeah.
than we currently are. We seem to think that these are somehow crazy people who have weird ideas that we don't agree with, and kind of, can we convince them otherwise? And we can't.
Yeah, I agree with you that that persuasion is not going to be there's a lot of the communicators we talked about, can we just shift the middle, focusing on the kind of median voter, and if we can just shift them, we'll have an,
And it's fear-based
yeah,
politics, and it's
yeah,
status anxiety.
yeah,
There's a real phenomenon
yeah,
here, and ideas are driving
yeah,
mobilization politically. And so when I see that backlash stuff, I go, yeah, that makes
yeah,
a ton of sense to me.
yeah. Well, I can answer the question in a few ways. One, I think that in sort of the circles that I'm in communication, people are talking about that, thinking about, okay, if the goal is not like thinking about those different paths to policy change, right? This idea that we just educate people enough, they'll come to understand that idea, they'll come to on some linear model, they'll come support the policies, and we'll get through this moment is largely untrue and doesn't hold up. And then there's other people in the conversation that I'm in who say, well, we got to focus on the outcome. So if the outcome is thinking about, let's advance policies that will meaningfully improve people's health and reduce inequality, the ways to get there might not be that persuasion path to them. It might be mobilizing people to act. It might be dissemination of policy from a small, focusing on local politics and thinking about making policy inroads in a local community that then demonstrates that something can work, and then having that dissemination outward rather than thinking about having it happen at any kind of national level. And then I think there's also what you started the comment with, thinking about different ways of frame the issues that recognize the importance of race, but don't require people to understand racism as the mechanism that contributes to the inequality. So maybe it's explaining the policies that contribute to people not being people disenfranchised or unhealthy or whatever the outcome is, and explaining what policies there are to undo that, where you talk about not the causes of the problem, but the policy, which gives people a better understanding, I think, of how things can be changed, rather than focusing on a problem, which sounds also, in addition to raising these heuristics, also sounds intractable, right, and contributes to that fatalism. So those are kind of the three pathways I'm seeing in some of the communication and political science research around this. But there's certainly a role for sociology. Huge role.
Well, I mean, to define what we're up
Yeah,
against,
yeah, yeah.
us
And putting it in context.
yeah.
So we're at time, I'm sorry. But thank you very much for being here. And the talk will be posted online probably tomorrow.
Thank you. And just to acknowledge my funders and team. Thank you so much.